Good morning, everyone. Welcome. This is May the 8th, 2023, and I'm here. I'm Lori Asmus. I'm the Manager of Volunteers and Holistic Services with Hospice of Cincinnati, and I'm very excited to offer our 11th hour class today for our volunteers, those who are part of the doula cohort and others who are interested in becoming better 11th hour volunteers. So away we go. A few resources that we have that I want to encourage you to ask for, or we can mail them to you, or you can have them pick them up. The biggest one is this guide for caring here. The guide for caring is kind of the #1 resource that Hospice of Cincinnati uses to educate our families. And so it's really critical. This is a tool that you'll use as volunteers in helping to reinforce that education. We also have a number of education sheets, which are like a little bit deeper dive into specific areas, such as morphine use, delirium, terminal agitation, and those are also available. You can get hard copies from the volunteer office, or you can find those on our website under caregiver resources, and they're all available for download. And it's just really helpful and useful information. So I'm going to go ahead and launch our presentation and hopefully share this. There we go. Share. Okay, excellent. Thank you everyone again for being here today. The 11th hour, it's all about providing compassionate presence in the final hours of life. And it's very important to note the word presence. Presence is going to be kind of the key word throughout our entire presentation today. I'm going to talk to you a lot about how our team functions, our Hospice of Cincinnati staff, in caring for the patients, and how volunteers help to supplement that care team. So this will give you hopefully a complete picture of what the final 24 to 48 hours can look like for patients and families in our care. So the biggest thing to think about is the 11th hour. It is an hour. It's not a minute. It's not a moment. It's about the entire journey. And we define that as the 24 to 48 hours, typically of life, when someone is diagnosed as actively dying. And our goal at Hospice of Cincinnati is that no one dies alone. But that does not necessarily mean consistent back-to-back bedside presence. What no one dying alone means is that people feel supported throughout that entire 11th hour, and they feel like they have resources, they're well cared for. And that could be with consistent presence, or that could be with education, or that could be with the intervention of a nurse or a social worker. And I want to say that the thing that makes Hospice of Cincinnati and hospice care in general different is if you were to pass away at the ICU or in a hospital-based system and not in the hospice care setting, they would focus kind of on what's lost. And we really focus on what is left to do to help that person, whether it be their hearing, their comfort, less on trying to resolve symptoms or terminal illness, and more about trying to take what's left and make it the most meaningful experience. And a lot of it, and I love this word, equipping, a lot of the 11th hour is our staff serving, but a lot of times it's more about equipping the family to really support their loved one through the journey. So it's a lot of education, it's a lot of teaching at the bedside, it's a lot of encouraging, and a lot of that is the role kind of I like to share of our volunteers, is really to help to be a translator, because a lot of families have never been in this situation before. And their role is going to be very much like yours. They're going to be providing bedside presence. They're going to be supporting their loved one. And so the fact that you as a volunteer may not have a clinical role and can demonstrate and translate and basically have a shadow for how the family can do what you're doing to support their loved one. And that's what I mean by equipping and coaching. And we really want them to get to the point that they feel like they are confident in supporting their loved one, because that helps with their own feelings of guilt, of helplessness, and anxiety. So it's really as much about equipping as it is about serving. I like to start with this quote that from Leonardo da Vinci, and I love it because it makes it just, you don't think about death as being happy, but if you parallel it to, as a well spent day brings happy sleep, so life well used or lived brings a happy death. And I think that death is something that we will all experience. And so the goal is that you have a life well lived and you can pass with that happy sense of completion and fullness and peace. And so in that way, we think of, that being a happy death, or you may hear some of our team or some of our volunteers call it a beautiful death sometimes, which is a very interesting dichotomy. So what is the dying process? Again, it's not just the moment of death. It's a continuous process. It could be weeks, days, hours, and can be very difficult to predict. So there's several stages. The before death stage would be kind of from the moment that somebody is diagnosed as terminally ill, which is at 6 months, certified by 2 doctors, but we know that they can continue to recertified depending upon how sharp their decline is. But there's a lot of pre-work that goes in when the patient still has a very high level of consciousness and can be very active in preparing their affairs or helping with their life closure goals. And then we have sort of the imminent or active dying phase, which we've defined as, the 11th hour, which is that period of time of transition. And I like to parallel this to birth. So think about before death is kind of like the impending, and the 11th hour is like after the water breaks, so that you can say that okay, this is definitely moving ahead. It's we're on the track, and we're now preparing for all the tasks and events that will occur in the next 2 days. And then you have kind of the moment of death, which I think in our culture, we really focus a lot of our attention and our sense of duty and purpose around that moment of death. And I think one thing that we can do is help to expand people's vision about that and help them to understand that it's really, if they're able to be there at any point in their journey, that is a wonderful thing. And then you have the after death. Sometimes people will say, oh, they've died, I can leave. We really don't want to leave our patients alone until like they've been a warm handoff to somebody else, like the funeral home. So that is a continual part of the care, is helping to be present until they are escorted out, out to their provider. So before death, our team will be focusing on preparing the patient and family for what's to come. And depending upon their disease process, that could be a very short decline. It could be a very quick decline. I will tell you that we have our average length of stay at Hospice of Cincinnati, which means the amount of time that people are in our program is 7 days. But averages are really difficult because we could have somebody that is admitted and dies within an hour. Honestly, it can be that quick of a turnaround. And we can have somebody that can recertify and potentially be there for 3 years. But the average length of stay is 7 days. And I think that we're making some headway in terms of having people sign up earlier because they can benefit from the care. as soon as they're qualified. What I think is helping that is palliative care. So we now have about 715, I think, patients in our hospice program, but we have close to 400 in our palliative care program. So our palliative care program would connect with people who are maybe in the hospital, have advanced chronic serious illness, something that needs to have the signs and symptoms managed by a nurse practitioner, and that nurse practitioner would do several visits with them, one of which is to get their affairs in order, to offer advanced care plans like a living will, a DNR, kind of a care plan, an emergency plan, and then and try to help them get their symptoms, and then also look at their resources and support to keep them honestly really well and in the home. Because what we've seen in our country is that people kind of have an illness, they run to the emergency room, and sometimes there's not a whole lot that can be done. They sort of and it's kind of they treat them and street them is the term that they use sometimes, which is that, you treat the emerging illness and then they kind of go back home, but their quality of life is maybe not better, or they're not managing their day-to-day condition any better. So palliative care is really about helping to do that. And the nice thing about palliative care is they can begin kind of warming somebody up to the idea that hospice care may be something that they would want to pursue, and can kind of dispel some of those myths. Because hospice still carries a pretty heavy connotation for a lot of people in our culture. But I think that the palliative care is starting to really enhance the utilization. And we expect the utilization to actually double in the next 10 years. Part of that is the population, part of that is our health systems are more focused on proactive care. So I think you'll see more of that. In addition, the nurse or the social work team is going to encourage people to say goodbyes. They're going to talk about their end of life closure goals, which is when, your lasting wishes and things like that may come up. It may be that we encourage people to come and visit, that we have them kind of prepare their legacy or to go through their photos, help with all of those things. Also, we would ask them to complete a vigil plan. We would ask them to talk about what is it that you want at your end of life. Do you want to be at home? Do you want to be in home in a facility? And how can we help to facilitate that for you? So the tasks of the dying, a lot of times we think about patients as being in a bed and, things brought to them, and, what do they have to do? They're taken care of, but there's a lot emotionally that has to happen. And that kind of in the final hours during the birth, the 11th hour, it sort of turns into the physical, or from physical to emotional. That really can help allow them to let go and transition. So they have to release their past hurts. Sometimes that may include things like our veteran to veteran program that helps with trauma-informed care, forgiving others, forgiving themselves. Certainly in those final hours, there's kind of a moving away from the physical world. So a disconnecting from that, both mentally and I believe spiritually. You become less connected, and really kind of a time of unbinding and letting go. And it doesn't happen instantly. And it's not something that somebody can just make their decision. I'm ready to go, so let me go now. It does take a journey. And I think about my 90-year-old great aunt, who was so sweet. She planned and planned and planned, and she was so excited for her 90th birthday party, and everybody came in, and she had the best party. And then 2 days later, she was angry. And she was angry because she had not died, because she was ready to go and she had done what she needed to do, and it was time to let go. And she had prayed to God and was ready to go, and nothing happened. And that was frustrating for her. And so we really had to work through with her how, we didn't know why her time was still lingering, but what were we going to do with this time that she had, and kind of change the sense of purpose that she had around planning her party to a different sense of purpose, which was preparing letters for all of her grandchildren for each of their birthdays, weddings, graduations. And that gave her that same sense of purpose. So you can't just make up your mind. Death is not a light switch that you can turn on and off when you want to. It's really kind of a process in and of itself. Other things that happen before death that we see is we see this kind of near-death awareness. And that's where the delirium sheet will come into play. And really kind of people become more confused or disoriented. And certainly their medications can play a factor in this, but even those who aren't medicated will begin to suffer with some confusion or disorientation. They can see things. People, sometimes they'll see people that aren't visible to us. They could describe another world. They could be revisiting a previous time. And sometimes they'll tell you exactly, when they think they will die. Oh, you can stay here. Today's not the day, or I'm feeling good today. They can also kind of use some symbolic speech. So if they start talking about packing their bags or needing to get out of bed to do something, sometimes that's a part of that terminal agitation. Is like, think about when you're getting ready for a trip. You're like running around the house and finishing the dishes and setting the timers on the lights. And there's a million tasks that you're doing. And, the dying, they have that same sense of urge. It's a form of nesting in a way that's really specific to end of life. So I referenced the Guide to Caring. Each of you have this here. This is provided to every hospice admission, and we want you to carry extra copies with you to provide to the family as well. Because one of the things that we do is we have to really train people who may not have ever experienced a death before very quickly, and how things are happening. So it's sort of like building a bicycle while you're riding it and having another person along as a passenger. So we're trying to really boil it down. And if there was only one thing that our families read, this would be it. So having extra copies and having them available to pull out and share with people, because also we know that we may have given the materials to the primary power of attorney, but families can have lots of people there who are a part of the process. So it's really good to have it. We also pull it out when the patient is actively dying, and the RN will review it literally and look at. First, they'll start with the question, what is your understanding of the signs and symptoms of impending death? And try to always assess what someone's one level of comfort is with discussing what's coming up, and number two, what is their understanding? So for instance, somebody in the medical field, we probably wouldn't want to insult them by going through a lot of really specific details. But somebody who maybe is not as familiar with it, or has never experienced someone as they have been dying, we would maybe do a little bit more detail. The other thing is we ask for the questions, what are your fears and your worries? And that really helps to guide the conversation. Some of the common themes that we hear a lot of is we just want them to be comfortable. We just want them to be peaceful. And so when people use those kind of words, it is an indication that they are ready and that they are accepting of the impending death. And what they're really fearful of is suffering. So death to them is acceptable, but suffering is not acceptable. And I would say that's where the majority of people are. And once they've been in hospice care, if they've had the appropriate amount of time interacting with their care team. Now, somebody that's been recently admitted may not be there. And they really may be very hesitant to even use the word death or be sensitive to that. And in that instance, you would be talking more about the symptoms and less about the impending death. Because the truth is that people have to get to that level of acceptance in their own time. And if we rush them, it will destroy the relationship, and they will feel like they have not been heard and that we've not been compassionate with them. So we really want them to lead with and meet them where they're at when we review this. And then we'll talk a lot about kind of what are your goals and priorities. So one of the things that come up is, are you prepared to be with your patient? Are you prepared to provide that presence? Are you comfortable with providing that presence? Do you have others that can come and be a part of that with you? And so kind of having those conversations. And they would start to go through this book. And specifically, when you look at this book, okay, there's a couple different things that you'll notice in here as continual themes. If you're uncomfortable and you see a symptom, call our nurses first. Okay, don't call 911, don't go to the emergency room. Okay, we really want them to reach out to our support team. Our support team is 24/7 and is available by phone, and they have people that they can send out to do visits if there's I would say uncontrolled symptoms. Okay, and we want to encourage people to reach out immediately if they're seeing something like that. So you'll see that written throughout a lot of times in this book. The other thing that you'll see written a lot is this is to be expected, this is to be normal, because what we're doing, a lot of these symptoms are very common and are a normal part of the dying process. And so what we're doing is reassuring somebody that while their loved one is experiencing the symptoms, they are likely not aware of the symptoms because of their level of consciousness. Okay. So let's talk about some of those specific symptoms. Pain. Okay. Pain, management of pain is one of our top priorities at hospice. That's one of the things that we are known for doing the best at, and what we absolutely do not want to drop the ball on. So pain is very, very important to us. And a patient will have ongoing assessments and adjustments to their medication. And it might be every single dosing that they have, go up a little bit, or they have, a different change, because they're going to continue to monitor. Again, we want to ensure that people are not suffering. And a part of pain management is stopping that. In the back, we had the morphine, the start low and go slow. That is kind of our general purpose with morphine, is that you really want to really start with the minimum dose needed. And we have medications that are called PRN. Okay, I don't exactly know what PRN stands for. Maybe Audrey does, but I think it's on demand. It's kind of like an on demand or as requested medication. And do you know what it means? It's yeah, it's Latin. It's Latin. Thank you. Okay, it's Latin. But it means sort of on demand. And that is one of the things that we actually look at in terms of if somebody is acute, meaning that they have a symptom to resolve, or if they're more routine. Okay, is the number of PRN medications that they've had over the last 24 hours. Okay, because if somebody is being managed with a schedule of medications for 24 hours, then that's a resolved symptom. And unfortunately, like what we get a lot of is death is not an unresolved symptom. So somebody dying is not necessarily a reason for them to be acute or a medical intervention, because it's to be expected in hospice care, which is really, you almost really can't say that, but that's the truth of the matter. So, but suffering and pain and uncontrolled substance, those are things that would make somebody acute and would make them need to be managed. And I want to, the caregiver may be providing some of this medication. A lot of times the nurses will fill syringes for people to use so that they have that available to them. They also will use pumps, so that maybe they'll go with like a dosing pump that they can take home. And then we'll continually check back for changes. And so that's why we want them to really stay close at hand with any type of additional changes. Fluid and food. So again, there's another handout about fluid and food, and it covers a little bit in our guide for caring. But essentially, people will stop with their appetite, and they may even start to prefer bland food. So sometimes people may not have an appetite for that special meal or that special thing because they're just their taste buds have changed. And this is all a part of the body conserving energy. Is it's saying, I'm going to keep the blood flowing and the heart pumping and the brain working, and I'm going to deprioritize digestion. And so actually, if somebody has no appetite, it's not a good thing to really encourage them to eat because they may not be able to digest it, and it could lead to constipation and pain. So we refer to that as like when somebody they start having bites and sips. Bites and sips is kind of the terminology for when we say somebody is starting to enter into that potentially 11th hour period. It also, taking in a lot of fluids can lead to swelling and congestion, which can complicate their breathing. And so, and the limbs, the pain in the limbs. And so, if somebody is not asking for water, then it's better to use ice chips and mouth swabs to kind of help them with their thirst, rather than to look at create that excessive swelling. And that edema is something that like light and gentle massage can help with, to help alleviate some of the pain and help with some of the drainage. So, and part of the swelling is because the kidneys are shutting down. So the heart and the kidneys are shutting down. I'm going to review kind of urine output a little bit more about that. We also see restlessness. So repetitive motions of their arms, legs, twitching of the feet. We don't want to restrain people, but we want them to be safe in their beds. So if they're getting out of bed, sometimes just a general reminder, creating that relaxing environment of not having too many people in the room, turning on calm music, giving them, if they sit up, just giving them a gentle back rub just to kind of get them to pause for a minute. Stroking the forehead just gently helps to kind of relieve somebody's stress and their tension in their face, which can alleviate their need to kind of get up and jerk. Also, same things, the stroking with the arms, starting from the shoulder and just not even using any pressure, just using the weight of your hand to kind of stroke gently all the way down and through can help a lot with that, those jerky, restless movements. Reading aloud, not reading loud, reading aloud can help with that. Poetry is beautiful to read, but the tone of your voice, no matter what you read, you can make sound beautiful. So sometimes just reading a book and using a very gentle tone and pausing a little more between each word, helps to create that soothing sound. It's sort of like when you have a baby, and you're tapping it, you're just gently tapping it. That's sort of what the stroking, that's the reassuring feeling that it gives. And sometimes you may go, oh, or hum with a baby, that's what the reading aloud can sometimes do as well. And that can help to release the restlessness. Urine. So kidney failure. Kidney failure is one of the things that is going to cause a sharp decline. Your heart and your kidneys kind of work together. So the heart is pumping to kind of move all the blood through, but eventually the kidneys, it has to go to the kidneys that have to disperse it into urine. And when the kidneys stop working, the heart starts to block up, and that's where you get a lot of the swelling. So you could see, and that's why we don't want people to take on additional water, because it just further burdens that entire system. You will see the decrease in the output, or it will completely stop. So, measuring output every day is something that our nurses do. Also, color changes. I mean, it could be as dark as tea, iced tea. And that is a sign that their urine and their kidneys are failing. And really, it's what happens is when the kidneys stop, there's a buildup of a toxin that happens. But the toxin actually creates a level of sleepiness, which leads to the reduced consciousness. And essentially, the person kind of goes into a coma. Okay. But that is the majority. It's actually a pretty peaceful death when somebody's kidneys, when they fail and that toxin builds up and it creates that sleepiness, it actually creates a pretty peaceful death for them. So the toxin building up is not always something, people will often say, well, can you give them Lasix? Can you help them with their decreased output? And the truth is that Lasix are kind of, they're gonna dry the person out. They're probably gonna, they may cause the heart to dysfunction, and it just really long term may not help them with the overall issue, which is that they're dying. Their body is shutting down. And so that's why we have our medical director do a lot of talking about diuretics and things when people start seeing swelling. Bowels, constipation. So it is a side effect of a lot of the pain meds. Pain meds work by slowing down the pain receptors in the muscles, and that includes slowing down the soft tissues of the digestive system and of the colon. And so the colon can get pretty backed up. We use a lot of Senna or Senokot, which is a natural way to kind of help to stool softener. We'll also use enemas. We have encouraged people to use massage to have the bowels move. And then at some point, we kind of determine when you hear bowels are not a priority, the medical doctor has to write that for us to stop treating the constipation. Is to say that essentially it's okay for them to be constipated because they've reached the stage where their other body functions have taken priority. And then disorientation. So about 70% of us, and I thought this was an interesting statistic, will experience some form of confusion before death. And so they determined that there's good confusion versus bad confusion. And it kind of goes back to that whole idea of, is the person suffering? And if they're aware of that confusion, is it creating anxiety, fear, worries, alarm in them? A lot of can be done with listening and patience, and then distraction. Distraction is an amazing tool. It's difficult with people that are in confusion to sometimes interpret language. Language can be, no matter how slow, how few words you use, language can be a very difficult thing. Even though they may be speaking to you language, they cannot necessarily process the words because they're starting to lose their sense of vocabulary because their brain centers, their frontal lobe is shutting down first. So I like to say that the number one thing is nonverbals. So think about using your nonverbals. So a smile, you know, a simple smile. Sometimes I'll go into a patient, and if they're agitated, they're trying to get out of bed, I'll just make eye contact with them and then just very gently swipe their forehead, hold their cheek, and just connect with them with a smile. And it will set their tone, and they'll change that anxiety to, it'll soften. And so think about just that tenderness of the nonverbals that can help to calm them down, you know, and then hold their hands so that they know that you're right there, and just give them that moment of presence and attention. But eye contact, smiling, and that simple touch can do another. The other thing that can help a lot is smell the flowers. So if you have, if almost everybody has flowers, or you can even, you know, use something, but you hold the flowers and you just, and you smell the flowers in and out, and then you have them mimic smelling the flowers like that. And that is a way to get them to deep breathe without telling them to deep breathe and without counting to them. So it's an instant reflection of a mirror where your nonverbals are getting them to mimic with the same nonverbals that are helpful and relaxing to them. Another one is like hugging bears, you know, holding a bear or holding a baby and just going, oh, and then giving them the baby or the bear and having them hold it and go, oh, you know, it's just that peaceful moment that you can use with that. So those are some good distraction techniques to use. And then sleepiness. Sleeping is kind of the body's, you know, it's just so natural. A lot of people say, oh, they're sleeping all the time. There's nothing we can do. We don't need to be here. They're sleeping all the time. Well, presence is still important. I would say intermittent presence. But the person can likely still hear, can still sense touch, and their mindfulness is still there, even though they're not responsive. So one technique that you can use a lot of is guided imagery. Guided imagery, we're going to have a class later in that, can be incredibly powerful at talking through somebody's mind to help them to relax by encouraging them and coaching them with inhale and exhale. And as you exhale all the stress, all the tension that you're holding. And their mindfulness is still a function of what they can use. And you will see their body calm down, even though they won't necessarily respond. You can see their respiration slow. You can see their shoulders start to drop. You can see their feet relax. And so those are all signs of that the mindfulness is helping to relax the body. And we have some scripts that we can provide to you, or you can make your own scripts. We just ask that you make it very spiritually responsible to whatever the patient's agenda is. And they're great to read. Again, that reading aloud with the gentle voice. And you can even have the entire family participate and receive that guided imagery. It hugely resets the tone of the room and the environment for us to create, I like to say, that soothing womb that we need to be able to have that person go through their journey on. I mean, ultimately, the reason why the person is sleeping, and these are good things to say, is that their body is kind of in an internal struggle. And so they need to disconnect from the physical world to reserve all their strength for the processes at hand. And responding and holding conversation and being aware of the physical environment takes a lot more energy than we really recognize, because we are fully functioning and our body's not in that war. But somebody that is having that, it's very exhausting to them. And so we don't want to wake them up in their 11th hour. We want to essentially allow them to rest up for that journey. And it's sort of, again, like a baby. If you think about a newborn and what the doctors tell you, you sleep when they sleep. You're awake when they're awake, you know, and you hold presence like that. And so that's the advice that we want to give the family. And they shouldn't be so much concerned that they're not sleeping at night, because again, like a baby, they can have their days and nights confused, and that's okay. We want them to sleep if they're tired, because it is exhausting to them. Breathing. So there's a particular type of breathing pattern that commences with the 11th hour, and it's called the Science-Stokes breathing. The breathing centers in the brain. It's actually a specific area of the brain that goes through a transformation that causes these changes and patterns in this specific type of breathing that we see at end of life with gasping. Now, the interesting thing about it is that somebody's consciousness, their frontal lobe, okay, by the time they go through these breathing changes, their frontal consciousness has decreased to the point that they don't understand that the breathing changes. They're not aware of how their breathing has changed. So it's not creating pain or suffering in them as long as they're not looking like they're awake. You know, so if they're just sleeping and going through or seem to be in a semi-coma and going through the breathing changes, they're not suffering with those breathing changes. And so that's really important, because this is the hardest thing, I think, of most people to observe, and especially those who have never been with a dying person. So they're very painless and aware, but it's just difficult to observe. And then there's the death rattle. And I will say that some people are really sensitive to it being called a death rattle. So I always encourage our volunteers to kind of stay away from that word, even though that's what's going on. Just refer to it as it's just mucus that's not clearing from their throat. So a normal person who is conscious of that mucus would clear it. They would cough it up and they would clear it. But because they're not conscious, they don't even know that they need to spew it out. So that's why the death rattle happens. But it starts, the pattern is a loud, deep sighing breath, gasping, where the mouth may still be moving. So that's the first step, is a like that. Then you'll hear kind of a weaker gasping with less volume and noise, where it might just be. And then you will really see those shallow respirations with long pauses in between, where the mouth is truly fixed. And this is where somebody's mouth will get pretty dry and even inside on their tongue. And so we want to make sure that we're only using mouth swabs at that time, that we're not offering water or ice chips, because they really don't have the ability to swallow at that point. But that is the typical pattern of how somebody's breathing will change. And again, there's more here in this book, and we have some handouts on that are provided. Finally, we have physical changes. Their extremities get cool, and that can happen up to several days in advance. It just depends on how fast the body, because the body is pulling the heat and the blood away from the extremities to the vital organs. And so the body may actually spike a fever, trying to get, you know, and the heartbeat may raise, but the blood pressure drops significantly. And so if they're spiking a fever, a cool cloth to the forehead is kind of what we recommend. We never recommend using like heating blankets or anything heating the extremities, because all that's going to do is kind of prolong the process. So we really want, but we could use soft and gentle touch. And also, sometimes if they're spiking a fever, they may want to remove the blankets, and that's okay too. We just want to make sure that their private areas are covered. And then you'll start to see modeling. There's a saying we use, which is you kind of die from the toes up. So the toes are typically the first thing that we will see change. Sometimes I'll tell you, especially in those with like advanced diabetes who've had reduced circulation, their toes could get very gangrenous and may even fall off. And that is something that can happen. Here's some examples of some skin changes that you may see. So you'll notice the blotted purple skin. That's a sign, not a near sign. It would be really purple or really, red if we saw that. And then cyanosis of the fingernails is also a bluing of the fingernails is something that you might see. Okay, so I'm going to pause right there for just a second and ask if there are any questions related to our presentation so far. Let me go here. Let me stop that. Okay, so go ahead. Any questions? Just new information for people? Yeah, okay. Jackie, what would you like? Okay. Yeah. Yeah, so that is a very good question. What I will say is that Jackie's question was about what do you say to people who refuse morphine for their loved ones? That is a real tricky situation. And chances are the nurse has already kind of reinforced that as much as possible because they really do try to get people comfortable with it. I always like to, our role is kind of to be an active listening, and then we can offer our observations from other instances of what we've seen. But we want to encourage the people that we hear them and we hear their concern. What I have seen most often is that people want to hold off morphine early, but then they will eventually get to the point where they're like, if it's needed, it's needed. So it's just somebody's tolerance of when, not necessarily, overall. But we do have some people that, because of spiritual and religious beliefs, they hold out. And it's really hard. I always encourage people, especially those who are making their advanced care plans, like to sit down with their healthcare power of attorney, because that's the person that kind of makes the decision about your pain medication is your healthcare power of attorney, and make sure that they are in alignment with you about your use of pain medication so that it's either liberal or not liberal. And so that's kind of a tough situation. But our role would be just kind of listen and say, I can understand your fears, empathize with them. This is a hard thing to go through. Maybe ask gently, well, what is your concern about it? What is your fear of what it's happening? And if you can say, well, what if they started with just the lowest dose possible, and you can decide afterwards, if it's bringing them comfort, you can decide not to continue. So just because they agree to it one time doesn't mean that they have to continue to agree to it. They can do that PRN medicine and just kind of, one of the words I say is like, just sort of take the edge off, kind of a low dose to sort of take the edge off. And then typically if they see the benefit of it, then they want their loved one to be comfortable, so hopefully that is it. Please just briefly, a little more comment on what conditions determine the end of palliative care and the beginning of hospice care, and then the beginning of vigil care. Thank you, Robert Douglas. You actually gave us a great time to talk about this, because I am heading into kind of what our vigil process is. So now that we've reviewed all of what happens, I'm going to tell you like what our process is and how Vigil volunteers stay. The first thing to note is that HOC has dedicated, specialized teams for each function of care. Okay, so admissions. Our admission nurses are excellent at, number one, introducing hospice care to people, and then determining appropriateness and helping them get up and set up and transitioned into the program. And we have anywhere from 30 to 40 admission nurses that is their primary focus. Okay, doesn't mean that they can't do, emergency care, vigil care, routine care, but that is their skill set. And we have invested a lot in making sure that they are our top dogs in admission. Similarly, we have a support team. Support team helps in the overnight hours, typically evening, and they help to kind of get the person to the next day to where they would get to see their regular routine care or case manager, their nurse that kind of visits them during the day on a week, or a weekly or every other day visit. That's called the case manager, or their general routine RN. And then we have what's called a continuous care nurse. And that specific nurse could be an RN or an LPN. They are specific to kind of crisis. We used to call this crisis care, crisis management of people who have unresolved symptoms in the home. So they're very specifically trained for intervention in that way. And all of these teams kind of operate together in concert with each other within their different specialties. And so what happens with us is the RN typically, I want to talk about the typical scenario. So 90% of our patients are either in the home or in the nursing home. It's about 250 to 300 in the nursing home, and the balance are usually in the home care setting. Okay, so their nurse would visit regularly to monitor their symptoms. And when the nurse sees things like modeling, sees their blood pressure changes, notices their urine output, talks to the family about that the person isn't eating anymore, measures their level of consciousness. So a level of consciousness starts at a 1. All of us would be at a 1. Then the delirium starts to arrive at like the 2s. The 3s are pretty kind of just visual responses to pain. And 4 is when they're really kind of non-responsive to any type of stimulation. Okay, so they're looking at it, and when somebody's starting to get into that 2 to 3 range, and they're also looking at the change. Now, nobody has a crystal ball, okay, but we look at it, we try to say 24 to 48 hours. Sometimes people can go through like a sharp decline and then they can rebound. And that does happen, where they will go into the 11th hour and then all of a sudden they'll wake up and they'll have they'll start eating again or something. That could be because they've had some sort of an episode, maybe like a stroke, or maybe they've had something neurological, happen instantaneously that then has been resolved, and they can continue to their baseline. But typically when they start seeing these symptoms, the RN will designate them as actively dying or imminent. And we actually have like a big red banner that goes up in our computer that the RN populates that says this person is actively dying. At that point in time, then they're going to go through and do the guide for caring. They're going to kind of have a patient family, like a mini patient family conference, where they say, this is what we're seeing. These are the things to be expected. This is how we're going to support you in the next few days. And then also, similarly, our social worker and chaplain would contact the family to see how they're doing emotionally, what spiritual, emotional support can be offered, which could include visits for them, or it may include the chaplain calling their parish to provide, sacrament of the sick or anointments and different things that is consistent with that. And then we'll assess, are they grieving appropriately, is kind of the word that says that, are they an acceptance of the death? Are they all on the same page? Or is there massive family conflict or something along those lines? And then we start, so once the RN identifies that they're actively dying, and it could be as much as, 4 to 5 days in advance, we would start what's called SIA visits. So SIA visits are like 1 a day, 2 a day, 3 a day visits, where we will just start to increase our frequency of visits in preparation for giving the family more training, checking in, and kind of be proactive about that. And that would happen with our general routine RN, typically during the day. Now, we would have SIA, which it stands for service intensity, something else like that. I can't remember what it's called. It's actually a Medicare term. We would have our support team, like if we're just admitting a patient and they're already in the actively dying stage, our support team would go out and would help to provide those visits because they're not really established with a routine regional team yet. And then at that point, once they really start getting close, we get into the 11th hour. So the 11th hour options, and there's really kind of three possible paths that could happen, and it depends upon the patient's condition. Okay. If they have unresolved symptoms that have to be medicated or managed in the home or the long-term care, then we would send out that continuous care nurse, those specific people, the RN or the LPN that can do those specific interventions. And so we have a pool of people that are kind of like, special forces, lack of a better word, hospice special forces, that they actually are centralized, but they can go to all the regions, and their work is triaged and prioritized on a daily basis. So they would literally say, okay, we have 5 patients actively dying. These 3 require continuous care, and they send them first. Now, the minute that those symptoms are managed or resolved, that nurse may be assigned to a different patient. And that's where, kind of the value of our volunteers really comes into play, is that sometimes the crisis is kind of a family crisis. They're worried and helpless, and they don't want to let go of that nurse, like they don't want them to go because they're nervous, understandably so. And so, but they don't really need any intervention, like everything's managed. What they really just need is that extra presence. And so that's when, we could maybe have a volunteer or a family member, a social worker, chaplain, or we do have paid patient attendants. Our staff can become patient attendants and go and kind of tag in for that bedside presence to alleviate that continuous care nurse to go and treat those who are of a higher priority because they have unresolved symptoms. The other option that we have is an acute IPCC stay. So here at the Blue Ash unit, in any of the units, we have 3 levels of care: acute, routine, and respite. And so they can come, many of them will come for an acute stay if it's early enough. Like, we don't like to move people when they're actively dying. We would prefer to send them a continuous care nurse. But if the symptoms are just starting and the family is already struggling with managing those symptoms at home, then we can bring them in for an acute stay, which is typically 3 to 5 days max. And again, once those symptoms are resolved, they have to go back home. They could still be dying, but once those symptoms are resolved, they go back home. And that's really hard for a lot of people. But it's just to manage those symptoms in lieu of sending a nurse to the home. So those are kind of the ways and options that we have for our 11th hour. And I will say that while I've done all this, there is no typical death, because each person dies in their own way, in their own time, with their own belief system, and they kind of die with their own story. And so really kind of exposing yourself to a lot of different times and different people dying, different situations, is what's going to grow your skill set longer term. And so for our doula program, the thing that we're going to go into at our next stage is kind of our mentorship. So the same way that as a new volunteer, you would shadow an existing volunteer, we're going to have our doulas shadow our team members. So you may go out and do a shadow with our nurse, with a continuous care nurse, with a support team nurse, with an admission nurse, with a chaplain, with a social worker, to help to kind of show you what their role is and how you can support that moving forward. So that's the next step in our doula program, is the mentorship. So what is the role? But you do not have to be a doula to be an 11th hour volunteer. We are so excited. We have a lot of really wonderful Vigil companions in this room, those who have been here. And really your role is to just be a calm and compassionate presence. To be there emotionally and physically for the dying, and really to help reduce that anxiety and fear. And I would say to reinforce the education. Again, we're throwing a lot at people. And so just simply pulling out the book when somebody says, wow, their breathing just seems so labored, I don't want to, I'm worried about that. Say, I hear you, and I have this information here, and here's what it says I'm breathing, but I take your concerns seriously. I can help to call with you, and we can talk to the nurse about it. But this is what the booklet says. We don't want to go through and be like, well, that's normal, they're dying. Of course you wouldn't say that, but we want to take their concerns seriously, and we always want to escalate them, but at the same time provide that education in the hopes that it makes them feel a little bit more comfortable. And we want to avoid the questionings and judgments. I would say use the words, tell me more about that. Not like in the instance where Jackie said, why don't you want to use morphine? Maybe it's, tell me a little bit more about your feelings on it, and kind of just being very careful of our word choice and our tone. And you're also there to represent Hospice of Cincinnati, to share that we care about people at end of life, and we want to be there to support people. So how do you prepare for your visit? Well, we want you to remember to always talk to the patient, okay? And you always want to call, if you're assigned a Vigil case, you always want to call the main number, 891-7700, to make sure that that is still an active need, okay? Sometimes we will set up vigils, and we'll set up several times. And once the family has adjusted to it, they'll say, okay, we can do this. We don't need the volunteer anymore. Just send the nurses and the aides. And it's really that's a good sign. That's a sign that they've come to a level of acceptance and understanding about how they can support their loved ones. And really, during your visit, you're going to create that soothing environment using the music, lowering the lights, helping to share, can we take turns at the bedside? Having people to have light physical contact. I think it's okay for people to be upset and, grieving in the room, but we just want to be watching the patient and look for there being signs of this, they're finding it disturbing, and kind of enroll the family in creating that type of environment. So it's really a delicate balance between providing education and getting them to be, getting them on the path of acceptance versus it being received as being harsh or they're not ready for it. And so it's really important that our 11th hour volunteers and our doulas have great emotional intelligence and can read the room. And so that is a quality that we kind of require, is that people are able to do that. And so, using the word death is something that we need to confirm they are okay with using that word. And I like to always say, wait for it to come up from them first. So wait for death, wait for dying to come up. If they can verbalize it, then chances are that they're getting comfortable with this situation. I always say, like, refer to it as a journey or transition. That's a great hour, or 11th hour. Those are all great terms to use that are generally people respect. Say that you're here to support with your presence, create relaxation. A lot of times when they call me in for a doula consult downstairs, when we have a family and the patient's hanging on, I will say, I'm a doula. I'm here to provide relaxation and teach you how to provide relaxation to your loved one in your goal of keeping them comfortable and peaceful. And so referring to it just as that is a good thing. They don't always need to know that it's healing touch or Reiki or things that I'm going to be doing or massage. It's just a touching of the hands and the feet, And just know that denial is a coping mechanism for many people, and we can't really push them faster than they're willing to go. That acceptance is their individual time. And always promise to follow up even on the weirdest things. Like if they say something really off the wall and strange, say, okay, I hear you, and I will follow up with you, or have the next person follow up with you and escalate your concerns. Our new TriHealth brand, which everybody got volunteer t-shirts or can get at volunteers, it says, be seen, be heard, and be healed. And that's really the experience that we want to give our patients and our families, is we want them to know they're seen, they're heard, and their healing is still a part of the hospice journey. So what are the skills to be a volunteer? You have to make a difference. You have to have good communication, active listening, and a willingness to learn over time. Sometimes volunteers are like, I'm just not ready to get started. That's just not my thing. I just don't feel comfortable. I don't feel confident. And there's only so much that we can provide you with training in a classroom environment. Certainly going on a shadow or following another volunteer is going to make you comfortable. But at some point you have to like jump into the pool all by yourselves and try to swim. But know that there are lifeguards. We're all here to help you. And you can practice over time too. This is a great environment here at Blue Ash to practice in, because we always have somebody that's actively dying usually, and it's a way you can come in and spend time but not be the full support for somebody until you feel like you could be that presence to go. So we want to do that soft music. Sometimes people prefer silence. I like the spa channel on Apple Music. That's one of my favorites. We also have CDs and things, low tech if you want to. We really encourage one person at the bedside at a time. And we even encourage people to go ahead and schedule. You take your break now for an hour, go take a walk, go run to the store, go, get yourself a good cup of coffee, and then have the other person come and wait and take those terms. Take calls out of the room and kind of put your cell phone on vibrate. Ask other people to put their cell phones on vibrate. I don't understand the whole TV in the room. Like, I just think like news should be outlawed completely in hospice care. I'm just going to say it's so disruptive. It's not healthy. It's like awful to have that in the background. It just creates a level of stress that doesn't need to happen. And with regard to spirituality, we really want the patient to kind of their truth to guide our work. So remember, your agenda, your practice has no place. Often I will use sort of, I will say like more holistic words in nature when I describe, a person's journey. So one of the things I will say is, life and death is a mystery. Mystery is a great word to use. Your beliefs say this, and I honor that belief. And so tell me the language that I need to use to help encourage your loved one's journey. What are the words that you say that talk about, if they're saying go to heaven, if they're saying go see this person, if they're seeing, let go. What I will tell people a lot, and I think is really hard, is that they feel like they need to be there for the moment of death. And yet a lot of people, like I think it was like 40 to 50% of patients choose to be alone when they die. And I think what they're doing is they're saving their loved ones from that experience. They're protecting them from that experience. And I also think that there's something related to sensory, that they can sense the people in the room and it keeps them there as an anchor. And so we really want to have, I call them sensory breaks, times when the patient is completely left alone in the room so that they can disconnect if that's what they're waiting for. And their consciousness, like they shouldn't be prompting the person to come back from their level of consciousness, because that can be, I mean, why would we want to most peaceful journey of their lives, right? If they're peaceful, we want to encourage them to continue to be peaceful, say your goodbyes, and then, you know, leave it there and just offer a silent or a comfortable presence is what I usually encourage people to do, because for them to transition to the next world, wherever we think that next world will be, the veil, you know, the line from this world and next has to kind of disappear. And so they have to sort of make that transcendent journey by disconnecting from the world that they're in. And we need to encourage them to make that journey whenever we can. So know that we're going to follow the patient and family leads, and we're going to stay neutral kind of in the process. And remember, there's no typical death. Each person dies in their own way, in their own time. I can't say this enough, in their own unique relationships and with their own story. And essentially, I mean, I love this quote from Mother Teresa: no one should die alone. Each human should die with the sight of a loving face. And I just want to honor all of you for the beautiful work you do in providing that presence and that comfort at end of life. So I'm going to go ahead and stop for questions again, and stop sharing. Let me do that and see. Okay. And let's see what we have here from Megan Fisher. When it makes sense in the training, can you talk a little bit about patients crying out regularly or making verbal noises in the 11th hour? I think it is one of the more alarming things that could happen with the breathing and could be interpreted as pain. But my sense is that they are really not there anymore. Excellent, excellent part, Megan. So that would actually be a part of the delirium stage. And I would say that if they're, what I look for with suffering is if people, you can see on their face if they're in pain. Okay. So I always say, look at the brow, pay special attention to the eyes. You know, there's a very difference in screaming out and playing like, oh, like that versus, you know, with their head open and they're, you know, seeing things and they're wanting to be heard. You know, I imagine that the way people live, they die. Like, I'm a very verbal person. I'm probably going to be screaming on the way out. I'm just, you know, just thinking through things, you know, the way I am. And so it's part of their, you know, it's part of their journey. And using those distractions, using those nonverbal techniques, the smelling of the flowers, the hugging of the bears, the gentle stroking, you know, the relaxation. These are all interventions that could help, but ultimately, you know, they may need to be medicated for that. And we have Ativan, we have lorazepam, we have lots of good drugs. In fact, next fall, our pharmacist is going to kind of give us a top 10 drugs of hospice and how they're used and how they work and what the side effects are and what they might do, which I think will be excellent to kind of round out our knowledge. You know, they use Seroquel, we use sleeping drugs. So, I mean, we want the people to be generally be restless, but if they're confusion and they're crying out in pain and there's, you know, and there's concern in their face, then we will treat that. But if they're just loud, you know, that's maybe, if it's not bothering the family, it might not be a symptom that we, you know, completely try to medicate. There is such a thing as like chemical restraints, which is, we really have to be careful. There's a very specific process that comes into place to actually, you know, sedate someone. That is a legal state of Ohio controlled thing. So we hardly ever get to the point where we have, you know, conscious sedation. It's almost always symptom management treatment. Okay. Here's another question. I have a concern about the sensitivity of being with a male, touching a female patient and comforting them since I am a stranger. 100%. So I would definitely encourage you, if you're cross-gender, to not do a lot of massage. I think holding the hand is okay. I think even touching, you know, the cheek or the temple is okay too, but you want to be very cognizant about that. And the best way to do that is to always ask. If you're with a family member, even just describing to them how to do that. Like a lot of what I do with the doula is I'll actually come in for a consult, and it's almost like a little boot camp. It's like an hour-long boot camp. We'll come in, we'll sit down, we'll have a family meeting. I'll assess what everybody's comfort level is, their level of acceptance, and I'll get them to verbalize their goals. What is it they want? They almost always say, we're ready for them to go. We just want them to go in peaceful. And I'm like, okay, team, we can do this. You know, we're going to get together. We're going to create relaxation. Here's the game plan, you know, and that's what they really want. They feel so helpless when their loved one is hanging on and they don't know what to do, that they're, in my opinion, they're hungry for a game plan. And so we work with, okay, who's comfortable with massaging the feet? Okay, you're going to do the foot massage first. We're going to turn, who's comfortable with being the DJ? Okay, you're going to be the one that manages the music, you know? Okay, who's comfortable with, you know, helping to coordinate the visitors and the schedule? There's usually somebody that can do that. Okay, who's comfortable with doing the readings, the reading out loud, the spiritual? Let's give them. So I go in and I give them jobs because they feel so helpless. So we give them stuff to do to be proactive in their loved one's journey. And it changes their complete anxiety, fear, and worries, and makes them feel useful in helping with that. And so another one, it's like, okay, well, you know, let's figure out, and then you're in there coaching them on how to do that. And then you say, okay, you've done a great job. Everybody break. Let's go leave and let's talk about what we did. Let's talk about, you know, and that's the time when the patient gets to be alone, right? So they're completely relaxed and they're alone, and they may choose that time to pass. And so then we make a schedule. We're like, okay, we're going to do this again in another hour. We're going to follow the same relaxation game plan in another hour. And it's something that they can do, and it's a repeatable process for them that helps them feel useful and less helpless. So, and you'll get to observe that, you know, when you follow me at the unit, if you're in the doula, to be able to learn how to facilitate that type of an interaction. Okay. With the family present, one suggestion is to listen carefully to the words they are using and then use their words in responding. Absolutely. To calm their stress. Absolutely. Reflective language. 100%. Yeah. So if they're not using the word death and dying, don't use that word. If they are using that word, then use that word, you know. So you pick up, they call it passing on, or it may be, you know, suffering, you know, or if they're not using the word suffering, don't use the word suffering, you know, use the word restless. And so word choice can be incredibly important. And if you sense, I will say this, if you sense that somebody is not connecting with you, it's okay to say, you know, I'm sorry. You know, I'm trying my best here. I'm sorry if if this is so uncomfortable for you. That's not my goal. Help me to learn how I can best support you. How can I support you? You know, give yourself grace and give them grace. And it's okay to acknowledge if they're, you know, stressed out. Like I have had family meetings where, you know, you have typically the daughters are all up front. I'll tell you, this is my big thing. The daughters are all up front and they're sitting there and they're engaged, and the sons are in the back like this. their arms are crossed and they're not saying anything and they don't want to contribute and they're all this and that. And you know what? They're not going to participate in the family meeting. But what you can do is when you run the daughters in to start their massage and they're all this, you can take a minute and you can pull the son aside and you can acknowledge, say, I can see you're struggling with that and that's okay. You don't have to participate. Just being here, just your presence is helpful, and that is your only role. That's the only thing you have to do. And if you need to take a break, let's take a break together. And the one question I love to ask families, and it just kind of breaks the ice, it just breaks everything open, is you talk about the patient. You talk about the patient. What are your goals? How are they doing? What's your concern? You say, and how are you caring for yourselves and each other? And you just see them fall and they start to cry because they've been carrying this stress for so long and you've just allowed them to kind of let that burden down. And what you can do, and I did this last week on Friday, is they usually say, well, not very good. I'm not very good at that. I just want to prioritize my mom and all this stuff. And it's like, okay, well, you have to take care of yourself for the long term. So find micro self-care, getting a cup of coffee, taking a brief walk, taking deep breaths away, leaving the room and just sitting outside. These are things you can do. So start with a 10-minute break. If you don't feel like you can be gone for 30 minutes, just take a 10-minute break and assign accountability partners. So you can say, I can see that you're not very good at caring for yourself. So I'm going to make them remind you, this other person in the room, and you two are going to remind each other to take breaks, so that they can support each other. And they kind of laugh and joke. And then they're like, yeah, you're really bad at that. And you're really bad at taking care of yourself. So we're going to keep each other on track. Or give each other massages, like they can rub each other's shoulders. I've rubbed family shoulders. You really just have to think about things creatively as what is, possible to give them comfort. Maybe if you're sitting presence, you want to encourage that person to take a nap. You're there, you're available, let them take a nap. Other things that I'm going to try to get started, I've been kind of working with the club on this, is cuddle time. Cuddle time. Okay. Patients benefit from touch so much. And the touch they need the most is of the touch that's closest to each other. And what do we do in the hospital and hospice care? We sit the spouse in a chair and we sit the patient in a bed and we disconnect them. And so having scheduled times, they can't sleep overnight in the same bed with the person, but they can have scheduled time to have a cuddle in a safe and relaxing environment. And that's something that we want to encourage more of. We want it to be safe, so we want the nurses to be aware and turn off the bed alarms and things, but that's what would happen at home. They would be getting into bed with their loved one. So let's create that experience here. All right. Let's see here. Does the family ever get upset with you when you have had them leave the room after boot camp training, a loved one dies alone? Honestly, I will say I have never had that happen because I think that what we're giving them is, because they go in and they provide this service, like they're tending to their loved one through massage and touch and relaxation and reading and music, they feel like they've kind of served their loved one. They sort of feel like they've given and taken care of them. It's sort of like, changing the baby, and then putting it down for a sweet nap, and then being able to walk away. I've not had that happen. Although I don't, like, if somebody does not want to leave the bed, I don't require them to leave the bed. I just keep reinforcing, okay, now I know you don't want to leave them. It's okay if you do in the future. and try to be sensitive to where they're at. Because again, that's a part of acceptance as well. But you know, I've never had anybody get mad at me about that. Typically, they're just grateful that their loved one has passed peacefully. And they're sad about the loss, you know. It's not the death, it's the loss that hurts so much. And so we focus on the loss, tending to the loss. Well, we are at our time here. So if there's any more questions, yeah, right, Rita? Mm-hmm. Because there are no families. Mm-hmm. This, what you're saying is so different from what my experience has been. Yep. So Rita is saying that most of her vigil volunteering has been when there's nobody. And I think that that has traditionally been our use of volunteers. But I think that's part of what the doula role will now change, is that providing that coaching and that, you know, I could see a future where, you know, the nurse identifies the patient actively dying, they increase the SIA visits, and the nurse is kind of going to different people addressing symptoms, and we're putting the doula in there as kind of the first responder to help get everybody on the same page and give them these tools so that then the next 24 hours are as supportive as possible. Again, it's that equipping of the family to do it for themselves, which changes the experience, right? We will still have volunteers out there for those patients that are alone, but we're also looking at how do we support those who do have family, where the family is feeling less equipped. Volunteer, I take on expectation that all. No. Yeah. And well, what we'll do is we'll have like a crafted plan. So I'm working on the model, kind of our 11th hour experience, so to speak, as to like what the first person on a vigil is going to do. You know, this is what the first person on the vigil is going to do. And then they're going to write, they'll probably leave notes behind for the person that comes after them with the interventions that have worked, maybe even a little notes on the family or the spirituality, so that then that gets carried through as the plan for all the volunteers that come afterwards. Now, our goal is that the vigil volunteers would be, you know, just supplemental. Our goal is always to equip the family to serve the present, you know. And the reason why we get called in a lot of the times is either because they're alone, which we really can't change that, or because they're helpless. They're feeling helpless and anxiety about it. And so this is the way that we would kind of work towards that. So it might be that our vigil volunteer goes in and gives a dinner break, or goes in and, you know, helps with the first setup of it. And then for those that are alone, it may be that we still do those 2-hour, you know, segments. But I will say this, that we don't ever want to limit you to just the 2 hours. If you want to serve a longer period of time, we will let you serve as long as possible, but we want you to know your limits as well, you know. And that doesn't mean that as volunteers, you have to sit in the room the whole time either. We want you to care for yourselves the same way that the caregivers would. Leave and take a walk, go outside, go get a cup of coffee, you know. We're providing, you know, presence because presence is helpful, but really it's about kind of creating that same relaxing environment. And so part of the funding that we got from the Circle of Caring is for some 11th hour bags, which our doulas will all be getting, which will have resources in them for you to use, that when you do set up a vigil, you can give these things. Some of them may even include like a memory box, you know, that we give to the patients and families as an activity for them to do. Something for, you know, young children to do if they're coming to visit their loved ones or want to be a part of the family. So really trying to enrich the experience to be more holistic and not as focused on the medical piece of it. The medical piece will happen, but what people are really seeking a lot of times is that emotional support. So Okay. I'm not sure if you need to sign in, but Sandy Agricola, it's good to see you, Sandy. Thank you. All right, well, I'm going to go ahead and wrap up unless there's any more questions. Thank you to everyone out there. It was great to see you, and I'm really excited to have you. And I will be sending out this recorded series. Look forward to seeing you. Bye-bye. Okay.